Hello, welcome back to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, a reproductive endocrinology and infertility specialist, and I am very happy to be back online with you guys again tonight. We were off last week because we were getting ready for our Health Canada final reports, and as well, we were getting ready to go to England to see my daughter and see the Harry Potter play Harry Potter and the Cursed Child, which was interesting. So we are back, and we'll be back for a little bit now, and it's good to be back with you all. And because we just got back last night, I figured the best thing that we could do is just jump straight into your questions. So I will tell you one thing we will be reviewing soon is an up-and-coming randomized controlled trial article of the use of letrozole in a frozen embryo transfer cycle. Many of you who have watched our show know that we use letrozole in our FET protocol and have had tremendously good success rates. I think we were almost 100% last month, so that was pretty impressive. And looking into the data, they did not have randomized controlled trials on this, but they had several trials which supported the use. So now there's a randomized controlled trial, and I will likely review that for you guys next week. Definitely some interesting data to evaluate there. And not much new otherwise has come up except for the argument over whether or not people should be doing PGT, with some people calling the article that was recently published demonstrating that abnormal embryos can still yield a normal baby, essentially misleading. So interesting, we might review that in an upcoming show as well. For those of you that are regular watchers, please check out our brand new video on YouTube on unexplained infertility, or if you are new to the show and you want to learn more about unexplained infertility, it is a very detailed, guideline-based, very useful kind of trip through all the things related to unexplained infertility. So check that out on our YouTube channel. It should be the newest video. We had about 100 views as of this morning. So we just put it up last night. So check that out and give us a thumbs up if you like it. And just before we get into questions, remember to follow us on Instagram and subscribe on YouTube. Click that like button and comment. We always like feedback. So if you think there's anything interesting, let us know. And we'll go from there. The last thing I'll mention is kind of a apology to our friend Melissa McNichol, who got scammed by someone who claimed to be me, but instead of rahivictory.md had rahivictory.m.d, and actually said we were on a new show last night with Melissa there, but it wasn't done by us. So she messaged me saying, hey, can we, sort of promote this? And I said, Mel, it's not me, it's somebody else completely. So I reported to him and they took him down. Yeah. So watch out for the scammers. There is a lot of that going around. So watch out for the scammers. Remember, we are rahivictory.md. Some of you try and jump onto my personal one, which is just Rahi Victory. And that's pretty much for close friends and family only. So stick to just rahivictory.md if you want to know more about the fertility world. So feel free to shoot all your questions out. I am newly refreshed from my trip and ready to go. I apologize, I'm scruffy. I did not have time to shave this morning. So
still look great. Don't worry.
Thank you, buddy.
Do you suggest baby aspirin for everyone in a transfer cycle?
Yeah, we do. So we have a video on baby aspirin and its utility. And it has multiple benefits. So it improves blood flow. It has been shown to thicken the endometrial lining. It reduces preterm labor. It probably reduces preeclampsia in everyone, but definitely in high-risk populations, it's beneficial. So we are big believers in using the aspirin, baby aspirin, for our patients. There are some patients where you need to be cautious. For example, if you have a bleeding disorder, you're not going to use aspirin. If you have a stomach ulcer, you're not going to use aspirin. Certain conditions will do it, but by and large, it does seem to improve outcomes. So we use it quite a bit. Do we have to stop it? Yes. In fact, I stopped it on someone today who was pregnant from a frozen embryo transfer and was having some spotting or bleeding, but you still have options to restart it later on. Or just be cautious and get people to get pregnant on it and then stop it soon into it if there's any kind of complication.
And Dr. V, do you use embryo glue while doing IVF? I've been hearing about it and wanted your thoughts.
So we didn't, but we do now for people that have had failures. My lab director has been doing it, and actually, so far we have not charged people for it. She just feels like if we fail, we owe it to people to do whatever we can. So we've been doing it for free. It does seem to improve the success rates in people that have failed. We have a video on it which demonstrates that it is beneficial. So yes, we are using embryo glue. We don't use it for everybody. It's expensive, but we do use it. The other one that will be on an upcoming show is the use of GM-CSF or Neupogen in the culture media for patients that are trying and having a lack of success. You can use it in 2 stages: during the embryo development and in the frozen embryo transfer thawing media. So when you use it in embryo development culture, it's actually very beneficial, and that's been proven. And when you use it in the frozen embryo transfer media, there's a new study out, and I won't tell you yes or no yet, but I will tell you that we'll be reviewing it. So that's up and coming as to whether or not it's beneficial in those patients. That'll probably be in 2 weeks. So stay tuned. We will share the info with you and see if it's worth it there. It is extremely expensive. So on that one, for 3 milliliters, it's $600 or $650, and you need 1 mil per patient. So we will likely have a small increase in charge, but we're going to work that out and see what we have to do for you guys. But again, for the patients that have previously failed, we are actually using GM-CSF culture media for their embryos if they're doing another cycle. And we're not charging them for it yet. So we may do it if we end up adopting it into the frozen embryo transfer protocol. So we'll let you know.
So a question came up way later. Like, it's a recent question.
Okay.
But it caught my eye.
Okay.
So I'm going to cut the line a little bit.
You're going to cut the line. There's going to be a lot of angry people.
I think it's a great, I think you'll have a great answer for it.
Direct anger at him. Just remember that. Yeah.
What would be the reason why some doctors are not supportive of Fertilis? Is it controversial? My doctor doesn't recommend it to his patients.
Yeah, so there's very little evidence, and I've always said that about it, for the infection component. The immune component's a different discussion. So remember, Fertilis does a lot of different tests. So they'll do sperm DNA fragmentation. Everybody should be doing that at this point. It's very clear that it makes a difference. They do infection testing for the vaginal and uterine microbiome. Now, it's controversial as to what the treatment for that does, but there's absolutely no discussion or argument that the vaginal or uterine microbiome have a huge impact on your success rates. So that might be why they're saying don't check it out, because we don't know if the treatment works, because there are no treatment-related trials. But we know for sure that if you have an imbalance of the microbiome in the vagina or the uterus, it will reduce your chances for sure. And then there's the whole immune side of what Fertilis does. And the immune side of what Fertilis does is the same as you would get from the Alan Beers lab or any of these other kind of big name labs. And they're just the exact same thing, but they're cheaper, and they actually give you a better explanation of what to do when you have an abnormality. So you can't argue against Fertilis, because Fertilis is not one test. It's a company doing multiple different tests. Do I believe in all of the stuff that they have? No. I don't believe in all of what anybody has, but I do find that the infection testing is useful. I'll give you a good example. We have people that have, second trimester losses, 16-week, 18-week, even 20-week miscarriages, where their membrane ruptures and they deliver. My belief, and it's backed by science, is that the majority of those cases are related to the fact that many of these people actually have infections either in the vagina or in the uterus, which are contributing to membrane weakening and or intrauterine infection. And what does the uterus do when it's infected? It wants to get rid of the infection, so it evacuates the fetus. So whether your membranes rupture or you go into labor or your cervix dilates, one way or another, the uterus is attempting to evacuate. So one of my very near and dear patients had a loss, and we put her on the Fertilis testing. We found out what was wrong. We've addressed it. We've actually kept her on antibiotics, and she's perfectly fine this pregnancy. So, it does work in certain circumstances. Is it going to work for everybody? Nothing's going to work for everybody, guys. So don't fool yourselves. But does it work for the majority of patients that we've used it in? Yeah, we are definitely seeing an improvement in results. And I will be happy to publish those when we get enough numbers. But right now, we probably don't have anywhere close to enough numbers to demonstrate even a grouping. But I am in touch with their guy, Veneriatos, Dr. Veneriatos at Fertilis all the time. And we have talked about doing research, so we may try and do something together. I believe it works. If your doctor doesn't, that's their prerogative. To me, it's kind of harmless. And in cases where patients have had failures, it does provide a hell of an explanation. So it makes sense to do it, because if you can adjust the microbiome, it will make a difference for you.
Is there such a thing as karyotyping for men? I have recurrent loss, and my doctor hasn't been able to find the cause yet.
Well, anytime you're doing karyotyping, it has to be done for you. And when I'm speaking to you, I'm assuming to the female, and it has to be done for your partner, who I'm assuming is male as well, because it could be you or it could be him. So you have to check for the men. Now, somebody asked me recently about whether or not it was valuable to do sperm aneuploidy testing. So iGenomics, the same people that bring you the ERA test, are capable of testing the percentage of sperm that have abnormal genetics in them. And obviously, if it's over a certain threshold, they are proposing that it will decrease your chances of success. I haven't gone and looked up the studies on that, because I don't think it's that valuable. And here is my rationale. Unless you, as a couple or as an individual, are willing to say, I'm not going to use that sperm, in which case it's either your sperm or your partner's sperm, but we're willing to use a donor if we find out that his sperm is not great, there's no value to doing the test, because it doesn't tell me, how to fix it. It definitely doesn't tell me how to pick the best sperm. Once you've tested the sperm, you can't use them. So we won't be able to tell you if it's genetically normal or genetically not normal. So that doesn't help you at all. And so it's pretty expensive. Last time I checked, it was about $800. And it doesn't help me in any way. So why would I bother? But karyotyping of your partner's blood to see if they have a translocation or abnormal karyotype, that is 100% necessary if you have either recurrent implantation failure or recurrent pregnancy loss. So for that, you definitely should get it done, not just for the female, but also for the male every time automatically, in my opinion.
Hi.
Hi.
Victory. It's a high wave. There.
Hello.
Which fertility doctor do you recommend in Chicago? I remember you mentioned it once.
Yeah.
Last evening.
Eve Feinberg is at Northwestern, and Eve is the smartest woman I've ever met. So Eve is amazing. She's brilliant. She's very, very good at solving IVF problems. There are many people who have failed before in other centers and gone to Eve and found success. So I love Eve. Having said that, if you're in Chicago, it's way, way cheaper for you to come to us, and we can monitor you there and just do your IVF here. So I'm not going to discourage you from considering coming to us, but if you want someone local in Chicago, Eve is amazing. I believe that Ruhi Gilani is also in Chicago, and I'm pretty sure Angie Beltsos is still there too. They're all bright women and very talented. Eve is extraordinarily bright and intelligent, and I absolutely love her. So you certainly can't do any better than going to see Eve. The other names I mentioned are also excellent in that area. So you won't go wrong by choosing any one of those three.
Do you use HGH for low responders, and how many weeks before stims is it usually recommended?
So HGH in the current data set, I think we reviewed it, does not demonstrate any benefit for poor responders. It does help you produce more mature eggs. So for example, we were reviewing the case of a lady today who should have had about 8 to 10 mature follicles, with some of them actually being fairly large, and actually had no mature, or sorry, she only had one mature follicle on the day when we did her retrieval. So I asked for her next cycle for us to add in human growth hormone in order to improve the number of mature follicles that we would get. But it is not beneficial for women with diminished ovarian reserve, and that's actually been shown in a meta-analysis. So it doesn't help you in that circumstance. So we don't use it for poor responders. DHEA has benefit, but HGH only actually helps you increase the number of mature follicles. And we do have a video on YouTube on that, so check that out. We really got to sit down and label all our videos, but it's on there somewhere, so we'll find that for you.
Hi, Dr. VNT. Just curious, before a frozen egg thaw, will there be any way to know if the egg is still livable from sperm injected?
So the question is, if you have frozen eggs, not embryos, before you thaw the egg, can you tell if it's going to survive or be functional prior to doing the thaw and prior to doing the ICSI with the sperm? And the answer is no, 100%. There's no way to know in advance, unless when they froze it, they froze really poor quality eggs for you. But if they froze mature follicles, there's no way to know ahead of time if it will survive the thaw or survive the fertilization or fertilize or even develop into a blastocyst. The stats on this are available. We've reviewed it a couple of times on the show, way back in the early days of the show. So it'll be like in the very, very early videos. But egg freezing is not nearly as good as people think it is. If you give it to an embryologist with exceptional skills, yes, you can get good results. So Dr. Khosravi, our embryologist, has phenomenal success rates, even with frozen eggs. But do we like giving her frozen eggs? I don't like giving any embryologist frozen eggs. So we try and avoid it as much as possible. But if you have frozen eggs and you want to get them fertilized, make sure you're doing it at a center with true expertise level abilities.
What do you advise? What do advise is the case acute constipation between FET and first trimester?
What do I advise for acute constipation between FET and first trimester? Anything for constipation in pregnancy is fine. So we normally start with Restorelax, which is PEG, 3550, and then we use Dulcolax, Senecot, Lactulose. Any of those are reasonable. Avoid things that constipate you, like bananas, apples, certain nuts. Take lots of fiber, lots of fluids. Take lots of stuff that keeps you soft and going, like prunes and prune juice, which is hideous but works.
How is technology to thaw a frozen egg nowadays compared to over 10 years ago?
Well, in the early days of egg freezing, they used a process called slow freeze, and none of them did well at all. Eggs do not freeze well in general. So you had to use better technology. Then they switched to vitrification, which is a process which essentially tries to freeze the outside of the egg without damaging the inside of the egg. And with vitrification, we do it for all our embryos, and then we do it for all of our frozen eggs as well. The results are much better. And then you have to use ICSI for frozen eggs because conventional IVF doesn't work with frozen eggs. So as long as you're using the right techniques and you've got a great protocol and you're being handled by a master, then you'll get good results. We've had very high embryo development and blast development and quality from frozen eggs in our program. But like I said, we try to avoid it as much as possible. But when it's needed, we can get great results.
Is a lining of 4 considered a lining that will be difficult to increase for FET?
No, it depends on what you've tried. So if you haven't taken estrogen, estrogen would be your first step. PRP, aspirin, vitamin C, D, E, Viagra, GM-CSF. There's a lot of different products you can use to improve your lining thickness. Now, if you've already tried, and plus hysteroscopy to see if there's scarring or damage in there. If you've already tried all of those things and your lining remains at a 4, that's definitely problematic. So in that circumstance, we would kind of hit you with everything we've got to try and thicken it. And then that's the one and only instance where I approve of doing an ERA test, because the ERA test is useless for the timing, but it is actually helpful for telling you whether or not you're receptive. And so as long as you're receptive in there somewhere, ignore the timing part of it, but know that that means that your lining can be receptive. And if your lining can be receptive, then you can go ahead and do a transfer. So I'll give you a great story, which I've mentioned on the show before, but we had a patient who had a genetic abnormality, and age was a factor as well. So we had to do PGT, and she only had one genetically normal embryo. And we got her embryo and realized this is like a once in a lifetime chance. She couldn't do the IVF again. So we said, we got to maximize this. So we gave her everything we could. We got her lining ready, excuse me. And we could not get her lining to thicken no matter what we did. It was like 3 millimeters. So I tried everything. Nothing would work. This is granted before GM-CSF and PRP, but we tried everything else you can imagine. Tried it, it didn't work. So finally I said, let's do the ERA test. So we did the ERA test. She came back receptive, even though it was only 3 millimeters. So I said, look, this is the best we're going to get. I've tried everything else multiple times. Your lining is not thickening. Let's go ahead and do the transfer. I mean, otherwise it's a surrogate. She said no. So we did the embryo transfer. She had a 3 millimeter lining. She got pregnant, had a baby. So it's not always numbers. And remember that throughout your whole fertility journey. People are so locked into, I need this AMH and I need that, FSH, and I need my thyroid here and I need my lining there. And it's not just about numbers. It's a whole picture. And the science is not, so precise that we can tell you if you have a lining of 8 millimeters or more, it's 100%. And if it's, 7 millimeters or less, it's 0%. It just doesn't work that way. So sometimes you can be successful even with a really thin lining. And sometimes you can not be successful with very thick linings. So, everybody's individual and your care should be individualized.
If I want to transfer to your clinic from a different REI, should I have my family doc write a referral to you?
Yeah, so if you're Canadian, get your family doc to write a referral, please. And then we will do our best to see you as quickly as possible. If you are American or from outside of Canada, just contact info@drvictory.com. Let them know that you would like a consult. We do it either by telephone or by Zoom. I usually spend quite a bit of time with my clients. We make sure you're comfortable with all the information you're receiving. In many instances, you don't actually need to come here because I can help you be successful where you are. We even have clients in Toronto that follow our protocol and that are successful with their own clinics. And then if you need additional help, then by all means, we'll see you out here and do whatever we need to for you.
After 5 months of suppression with Lupron and letrozole, do I need to have a period before transferring? Currently 71 days since last period and expecting to transfer by the end of May.
Not if you're fully suppressed, no.
Okay.
Easy.
How is a dual stim cycle different from a regular stim cycle? Are there 2 retrievals within one cycle?
Yeah, so technically the way a duo-stim cycle is supposed to work is that you do a follicular phase stim, you retrieve the eggs, you get all of the eggs that you can that are a reasonable size. You leave the smaller ones like 8, 9, 10, 11, 12 millimeters behind. You wait 5 days, you start another stim, and you go and you collect the next batch of eggs when they are mature. The problem is it's designed for women with really weak ovaries. So you're supposed to use it for women that meet the Bologna criteria, which are specific criteria you can all look up, that specify whether or not you're considered a poor responder. So like less than 6 eggs, you've done poorly in a previous cycle, your FSH is really high, your AMH is really low, those sorts of factors go into these various systems that will score your ovarian reserve. So Duo-stim is designed for women with diminished ovarian reserve. Fortunately or unfortunately, here at VRC, we seem to be letting loads of people do Duo-stim cycles, even when they don't meet the Bologna criteria, because they get the second cycle for 37% less. So you're really getting 2 cycles for the price of roughly 1.5, a little bit more than 1.5. So, or 1 2/3, I guess. So in that scenario, lots of people like it because they're saving themselves a ton of money and they're getting extra embryos. Unfortunately for us, what that ends up meaning is that we frequently have to split your cycle apart because we have lots of patients that are getting 10, 12 eggs in one cycle. And then we can't tell which ones are the new ones and the old ones when we go 5 days later to start a second stim. So we let them wait a month and then start a luteal phase stim in the subsequent month so that all the eggs from the previous cycle have disappeared and we can now tell which ones are good and which ones are bad. And it actually works exceptionally well. So we've had very, very good results with that technique and that protocol.
Are there any immune tests that can be done locally without doing an immunology portion of Fertilis?
Not easily. You could get your complement levels checked. You can probably get your you might be able to get your interleukin levels checked. You could probably get some things checked, like you could do an endometrial biopsy and have them stain it for various cell types in there that we look at, that we worry about. But it's going to be really haphazard, and without having like a rheumatologist order it for you, you're going to be paying for it anyways. So why not just pay Fertilis to get the full panel of what you need? I don't work for Fertilis. I have no financial relationship with Fertilis. The only thing about Fertilis where there's any kind of benefit indirectly for me is that I yelled at them to give our patients a discount when they get the package and they tell them that they want the Victory package. Aside from that, we have no benefit from anything, and that's no direct benefit for me. I'm just trying to help you guys. So that's, we use Fertilis because they are cheaper, and I like the company and what they represent, but that's the only time we use it.
I'm 40, PCOS, taking both Provera and Letrozole. My OB/GYN is sending me for blood work between days 20 and 25 of my cycle to see if I ovulated.
Sure.
This cycle, she told me I did. Well, my question is, because my cycle is long, what is the latest that one can ovulate, and how can you tell by blood work?
Well, you can tell by blood work because they're checking your progesterone level to make sure that it's rising, because you have to release an egg for your progesterone level to rise significantly. You can also potentially tell from an LH surge if you pick it up at the right time. But the best test is either pregnancy or seeing if the progesterone rise. So that's probably what they're checking for. In terms of how long can it go? I mean, it can go for a long time. You can even ovulate all the way out to day 21 and still expect reasonably normal cycle. However, in my experience, the people that take a long time to ovulate have significant diminishment in the quality of the eggs that they're releasing. So if your egg is taking 21, 22, 24, whatever days to grow, develop, and release, we frequently find that there are higher rates of miscarriage, more complications, things like that. So I tend to give those patients meds like Letrozole or Clomid or shots or whatever in order to accelerate that process so that you're capitalizing on getting better quality eggs.
Just had hysteroscopy with a scratch and biopsy. Can I start a FET right away, or should I wait? How long?
Well, if you're a believer, excuse me, that the biopsy actually is beneficial, which very few people believe now, then you should be ready to do your FET the following month, not the same month, but the following month. If you're not a believer, it doesn't make a difference. So it depends on which side of the coin you're on. The data right now is that it doesn't make a difference. So that doing an endometrial biopsy is not beneficial. But certainly there are lots of people that think that it can help. And there is some data that suggests that certain subpopulations benefit, whereas other subpopulations don't. So something to consider.
Hi, Dr. V. When should a patient start a baby aspirin? How much tablet per day?
Before you even ovulate, before you do an embryo transfer, 81 milligrams per day.
Hey, Dr. V&T, happy Eid.
Happy Eid, dude. Yeah. Tarek, by the way, devout and made it through all of Ramadan. Yeah, absolutely.
Do you recommend additional immune blood tests for those with Hashimoto's? Is there further research in the use of steroids, IL therapy, IVIG for those with high NKA levels?
So I'm not aware specifically of studies looking at immune protocols for Hashimoto's patients, but if you have Hashimoto's, you have a very activated immune system. And so likely an immune protocol would benefit you, just theoretically, not scientifically. From the standpoint of NK activity, yes, there are loads of studies that demonstrate that various approaches can benefit patients with excessive NK activity. And when you have those elevated NK cells, that can diminish your success rate. Still controversial, but I think the balance of studies is definitely suggesting that there is a benefit to treatment. And I can tell you personally that we have seen that. So it does make a difference.
TSH 2.5, would you recommend treatment prior to FET?
No, you need it right at 2.5. And I'm okay with it even being up to like a 2.75, 2.8. I don't panic about that because in the first trimester, it just has to be less than 3. So that's reasonable. You're aiming for a target of less than 2.5, ideally, but anywhere close to that is fine.
Can you please review the importance of the post-thaw culture? Should all embryos be monitored for a set number of hours before transfer, regardless of whether PGT tested or not? Are there any downsides to transferring an embryo that has thawed 20 minutes prior to transfer?
Okay, so we don't do embryo transfers for embryos that were thawed 20 minutes prior to transfer. I'm not sure who does, but that would probably not be advisable because your embryo needs to settle into its environment and you got to give it a chance to settle before you switch its environment. So taking it from cold to warm and then into the uterus warm with different oxygen concentrations and different, substrates and sugars and, cholesterols and all that stuff that's available in the culture media versus the uterine environment is not something where you go snip, snap, snip, snap. So you got to be careful with that. So I don't know of anyone that does that. If they did, they were either really rushed or worried, or maybe they had a good reason. I don't know, but I'm not aware of anybody. There are programs that thaw the night before. There's one in Toronto that does that. We don't do that because a lot of those embryos will hatch, and hatched embryos actually are not the greatest to deal with because they get sticky and they can stick to the plate or they can stick to the catheter. So typically we thaw several hours before we do our embryo transfer, and that seems to work out great for us. I have not actually looked it up, but it's a great question, and you got to remind me to ask Dr. Khosravi. So Dr. Khosravi, if you're watching, maybe you can text me and tell me what the ideal time is, but I know she does a few hours, so I'm assuming that's the ideal time.
Dexamethasone versus prednisone, which is better, and what are the standard doses for each?
So no one knows for sure, but Dex may be better. Protocols vary on dosing, although most Dex studies look at 1 milligram. Prednisone is highly variable. I've seen everything from 10 to 40. We use 25. Is there a difference? I've never seen a head-to-head comparison, and it does depend on what you're using it for. But there are a lot of studies on Dex, and we reviewed one years ago on the show, which showed that Dex actually improves things. I haven't done it again because we use steroids in our protocols. anyways, so we didn't go back to implement that, but you know what, we probably should have another look at that study. So yeah, my lab director got mad at me because I suggested I didn't tell you this. So she got mad at me because I suggested we add something to the protocol. She said, we got 100% last month. What are you trying to do? Get more than 100%? And I said, yes. So yeah, I mean, I'm always looking to make it better. So yeah, we do well, but there's no reason why we can't do even better all the time.
Got a big question for you.
Okay.
It's split up across multiple.
Oh, like a big question.
Yeah,
okay, fire away.
Bear with me here.
Okay.
Scroll to get to that part.
You got to scroll. It's a scroller.
Yeah.
All right.
Hi, Dr. V.
Okay.
We are really disappointed.
Oh, no.
I'm 40 years old and my wife's 34.
Okay.
It's 4 years. We are trying to have baby. My sperm parameters are borderline and my wife's AMH is low.
Okay.
We had unsuccess IVF and 1 IUI.
Oh,
the
sorry.
implantation doses not occur. The doctor tells
The implantation doses not occur?
or does not occur.
Okay, maybe the implantation does not occur. Okay, yeah.
The doctor tells the egg quality is good and embryo is type A
Uh-huh.
and AB, but the implantation wasn't successful. We are
Sure.
really frustrated. What can we do for find the problem and plan? I am from Iran and
Oh.
we changed the doctor because they didn't explain what the problem is. For example, offer egg donate or embryo donate without explaining what's the problem and said no problem before transfer. But
Well, this is like a real scroller.
yeah, that's it. It stopped there. It seemed like it was going to continue. Transfer BU.
Okay, so I am Iranian. I'm sure you know that already. So you should probably reach out to me and I can speak to you in Farsi. But I need to know more about you before I can tell you what to do. You know, low AMH means it could be an egg quality problem. Just because the embryo looks pretty does not mean that it's a good embryo. And again, same thing with the sperm, that can affect the quality of the embryo. So you need to reach out to me so I can explain to you what needs to be done. Just in case you need it in Persian, I guess I'll speak in Persian. So برای دوستان ایرانی که راجع به جنین و IVF صحبت کردن که چجوری میتونن اینو بهتر انجام بدن، بی زحمت با من تماس بگیرین از طریق آفیس و ایمیل بفرستین به info@drvictory.com و با همدیگه صحبت میکنیم که کمکتون بکنم. Sorry for all the non-Persian speaking people out there. Yeah, so get in touch with me and I will help you out.
After 5 months of suppression with Lupron and letrozole, do I need? Oh, we did that.
Yeah, we did that one.
Yeah. How is Duo-stim cycle? No, did that. During my FET practice run, my doctor said he can do the transfer because fibroid was in the way, in the wall. He wants to look into possible surgery. Must the embryo be dropped in a certain spot?
Well, that's a two-part question. So part one is, if you have fibroids that are distorting the inside of your uterus, in other words, pushing hard enough to impact the inside of the uterus, they need to be removed because they will significantly reduce your success rate and increase your miscarriage rate. The other part of that question is, can a fibroid interfere with visualization? I had a patient I did today who had quite a sizable fibroid, but it wasn't pushing onto the inside of her cavity. So, I mean, you just have to angle the ultrasound differently to get a good view. So I don't need to do surgery just because the fibroid's interfering with the view. But I mean, I would need to see your uterus to see if that was necessary. The other option you have is to do a transvaginal ultrasound guided embryo transfer, where you get a beautiful view of the uterus, but very, very few people know how to do that. We do, but very few people know how to do that. So that's something where you have to ask them if they know what they're doing, and then they can help you out.
Could you recommend a paper that describes HGH benefits? My doctor told me that he had seen patients with bleeding follicle instead of follicles that are synchronized while using HGH.
Her doctor told her that he saw people with what follicles?
Bleeding.
Wow. Well, you know
Instead
what?
of follicles that are synchronized while using HGH.
Oh, you know what? Let's go here. Lib.uwo. Ask me another question.
Sure.
While I
If you
look
transfer
this
two
one up.
embryos, one male and one female, and only the female is successful, is it possible that the male DNA can be found in your blood weeks later for a gender determination blood test?
Not if it didn't work. Definitely no. Um,
Another question?
HGH, no, HGH and IVF, I guess. The question was it for FET or for IVF? What was the HGH?
HGH follicles.
Oh, yeah, for IVF. Okay. So let's just do meta-analysis. Human growth hormone. Well, there's the effect of growth hormone supplementation in poor ovarian responders undergoing IVF or ICSI, a meta-analysis of randomized controlled trials. Yang, Y-A-N-G-P, is the lead author. It's in Reproductive Biology and Endocrinology, 2020, July 29th. That's my birthday. That should be easy. There's a Kolobianakis. He's very famous. That's from 2009, so it's missing a bunch of stuff. The influence of different growth hormone addition protocols to poor ovarian responders on clinical outcomes in controlled ovary stimulation cycles, a systematic review and meta-analysis. That's 2017. Like, all you got to do is go to PubMed and type in human growth hormone and IVF and select meta-analysis. And I've got 2 pages with at least 10 different studies in there, and that's meta-analysis. So there is loads of stuff to look for.
There you go.
But I give you 2. Fire away.
Second question. Don't know what the first one was. Dr. B, our embryo needed to be refrozen. Aside from the risk of surviving a second thaw, are there any known issues with embryos or children who have been frozen and thawed twice?
It's super controversial. So some people say you should never do it. Other people say it's perfectly fine. My lab director says avoid it when you can, but it's fine if you have to, if the embryo is a good quality to begin with. Excuse me. So if you have a bad quality embryo, it's going to probably be much more difficult to keep, alive. If you have a good quality embryo, you'll be fine.
I didn't know. Dr. B, sorry I missed whether you recommended the biome and endometrial testing for all patients or only for those recurrent losses in a few embryos.
The which one?
Biome and endometritis testing for
Oh,
patients.
Yeah. So the Fertilis testing to look for biome and endometrial testing, we don't recommend for everybody. We recommend it for recurrent implantation failure. So like 2 or more. Or people with very limited numbers of embryos, or if your history indicates that you have a high risk of infection, multiple previous losses, recurrent implantation failure at another center. You have very painful periods sometimes with no endometriosis or adenomyosis, history of multiple different STDs. You get bacterial vaginosis all the time. You've had multiple sexual partners. Anything that would place you at a higher risk for having the infections, second trimester losses, preterm labor, premature rupture of membranes, all of that stuff, that's the kind of time where we would, expect that you might find something in there.
Big question. Not as big as the other one, but some quantity.
Is this thing on?
Yeah, you're on. You're good.
I don't know if I ever turned it on.
No, you're on.
Okay.
Can you clarify the Fertilis combination of testing you typically recommend?
Yeah.
I have an upcoming consultation with you, and I would like to get started on trying to organize the Fertilis tests while we wait. We have had 3 failed FETs of euploid embryos and have unexplained primary infertility. We're both 33, healthy, and in good shape. Thank you so much for all you do.
You're welcome. You know what? My iPad's dead because I was away and I didn't charge it. So on the Fertilis website, when you go to order tests, there's a reproductive immunology panel, and then there is an menstrual infection test. So we use the advanced or full microbiome test. And then for the immune panel, you got to be one of our patients and we tell you what to order from them. So just give the office a call. And as long as you've had a referral to us to see us, we will give you the info that you need in order to get all of that sorted out. You contact them, ask them for the combo, and then they will send you what you need, and you save 140 euros, I think. So it's helpful.
Hi, Dr. B&T. I'm wondering, what is safe in terms of exercise in early pregnancy, 6 weeks? Any heart rate restrictions or weightlifting restrictions? Trying to be extremely cautious as we've had previous second trimester losses.
No heavy lifting or straining, so nothing more than 15 to 20 pounds. Keep your heart rate under 120. No tough training, no Peloton or, spin class or Tough Mudder or boot camp. Like, a light elliptical, some yoga, some swimming, like gentle stuff, but don't be going crazy.
Anything you recommend for possible adenomyosis? Thanks, Dr. B.
Lupron and letrozole, Lupron alone, or Alyssa, Vizan, any of those will work. If it's an adenomyoma, you may want to consider surgery, although I detest doing adenomyoma surgery, and I love surgery, but I hate doing adenomyoma surgery.
If you transfer 2 embryos, one male and one female.
You asked that one.
Oh yeah, in the blood, yep. Is it okay to go past your due date in an IVF pregnancy, or should I consider induction by a certain?
Yeah, so listen, I'll review stuff we reviewed. When was that?
I think it was last show.
Was it the last show, or was it the one before that? I can't remember.
One or the other for sure.
Just recently, we reviewed it on the show. So the question was, should you be induced or should you not be induced? So the answer is, there is overwhelming data demonstrating that everybody should be induced at 39 weeks. It is only going to be beneficial, and there is no increased risk or harm or decrease even in patient satisfaction. So certainly for IVF patients, you're not technically high risk, but you're higher risk than normal. And so I would much rather see you be in a safety zone. The problem in waiting is that the placenta conks out eventually, and IVF placentas are not as strong as non-IVF placentas are. So there is definitely a benefit to making sure you deliver at a reasonable time. Can you wait? Yes. Should you be monitored? Definitely. Is there a benefit to waiting? Absolutely zero. And that is being demonstrated in a randomized controlled trial, which actually showed that you increase the risks of C-section rather than decrease them. So what's the benefit of waiting? It's a higher risk of NICU admission for the baby. It's a higher risk of having preeclampsia for the mom. It's a higher risk of cesarean section, and patient satisfaction is the same whether you be induced early or you wait. So what is the value of waiting? There's absolutely none, zero. So we recommend induction.
I just got COVID and I'm 11 weeks. What can I do to make sure the pregnancy is healthy still? I'm fully vaccinated and boosted.
Take lots of vitamins, get some rest. That's all you need. Don't worry. If you've been vaccinated and boosted, COVID has virtually no impact on the pregnancy. It's only a problem if you have not been vaccinated or boosted.
I recommend vitamin C.
Tarek recommends vitamin C. Dr. Tarek, Dr. T recommends vitamin C. Yeah, echinacea, vitamin C, D. Those are both good for your immune system. Garlic, ginger, if you like the natural approach. Anything reasonable is fine, but you don't need to worry. Just lots of fluids, lots of rest. Cough syrup with DM if you need cough syrup. Halls candies, Vicks Vapor Rub, that stuff's all fine.
Why is preeclampsia more prevalent in IVF pregnancies?
Well, it can either be placental in origin, and like I just said, the placentas are not the same, or it can be maternal risk factor dependent. So sometimes the moms are older, that's a risk factor. Weight can be an issue, that's a risk factor. Previous history can be a risk factor. And then there's the whole issue of these placentas don't necessarily develop the same way as they do in a natural circumstance. So those are the theories behind it, but obviously there's no way for us to know for sure. My tea is cold.
Mine is empty. If you transfer two embryos, a male and a female, and
Asked.
what's wrong with these guys?
I don't know. That
They're
one keeps
cheating.
coming up. Yeah.
Yeah, that does keep coming up.
Yeah. If you didn't hear the answer to your question about the male and female embryo, the answer is there is no way that a male embryo that did not stick would show up in your blood on an NIPT test.
I haven't asked you this yet.
Okay.
What would your thoughts be on a low Mosaic 4 BC embryo from a 39-year-old? One doctor thought it was, I kept getting disconnected, but I think half my post went through, was just saying one doc thought the embryo was promising, another didn't because of my age.
Okay, so let's quickly learn about embryo grading. So the grading system is for the number describes the degree of expansion of the embryo. The first letter is the grade of the inner cell mass, the part that's going to become the baby. And the second grade is the grade given to the trophectoderm, which is the part that's going to become the placenta. A C grade placenta is definitely not ideal, but a B grade inner cell mass is good. So you've got kind of a mixed embryo. A 4 is great. And we have videos on all these topics, so you can check those out. But a grade 4 embryo is a wonderful embryo for transfer. A 4B is a very good embryo for transfer. A 4BC is an okay embryo for transfer. A Mosaic basically gives you a 50-50 chance. So within the realm of you being 39 and having this BC embryo that's Mosaic, you probably have still a decent chance. Would I transfer that? I would definitely transfer that before I try again, unless you can do IVF for free wherever you are.
Can a heart-shaped uterus impact pregnancy?
If it's heart-shaped on the inside and the outside, yes, you're at risk for preterm labor. That's called bicornuate, where the two horns of the uterus never fully developed into one uterus because they actually start as separate sides and then meet in the middle and fuse. But if it's only indented on the inside and the outside's normal, that's called septate. And a septate uterus has a huge negative impact on pregnancy. So those ones we do fix. There was a study not too long ago which demonstrated that there was no benefit to correction, but I literally don't see how that's possible because every single patient I fixed the uterus on has always gotten pregnant after a long history of recurrent miscarriages. So that just doesn't make sense to me at all. I don't know what they were doing in that study or how, but if you correct it properly, it will improve the outcomes.
Ready?
Always.
I am currently 9 weeks, 4 days pregnant.
Okay.
After an FET, we've seen the heartbeat at 7 weeks and 9 weeks. However, my initial beta HCG only rose 42% within 48 hours. Should I still be concerned about MC?
Probably not. Your initial beta is just one test, and depending on when you did it and who did it, and if it was the same lab or a different lab, I would not be concerned. Plus, in the very early stages of beta rise, it's not as exponential as it is later on. So no, I would not be concerned about miscarriage. There are studies that suggest that even in the presence of a heartbeat, an abnormally rising beta can still predict miscarriage, and that's true. But that would have to be persistent. So if it was just one time where your beta didn't rise properly, I wouldn't be worried about it at all. And congratulations.
Mohammed from Iran said thanks a lot.
Oh, perfect. Yes. Mohammed from Iran, get in touch with us. There
you go. Hey, Dr. VNT.
So he was actually from Iran.
Actually from Iran.
I think that's our first Iranian viewer.
100%. That's asking
Right?
questions live. Yeah,
Yeah,
100%.
live questions. That's impressive. We got to start advertising in Iran, man.
You go there. I'll go.
I am not going to Iran. They'll throw me in jail. I'm Baha'i, dude. All right.
Hi, Dr. VNT. Thank you for all you do. A cyst was seen on my first ultrasound 6 weeks pregnant, 4 centimeters by 2 centimeters. I think, is this the cause of concern? Could it just be a corpus luteum?
Oh, that's your corpus luteum. It's not a cause for concern.
All right. Easy see. Hi. Thank you for answering all our questions.
You're welcome.
You've helped answer some of my HCG wash questions.
Okay.
Thank you.
You're welcome.
I still have 2 more.
Okay.
Number 1.
2 more embryos or 2 more questions? Oh, 2 more questions.
2 more questions.
Okay. Yeah.
Do you change the catheter after inserting the HCG wash? And I still don't understand, how does the doctor get 500 IUs in a 1 ml vial? I'm doing a 3-day embryo transfer Thursday and have advocated at my clinic to do the wash, which they will be doing for the first time ever. I want to get all the details right. I printed the studies and highlighted the details, but it helps how you explain it in detail for me. Thank you.
I know who this patient is. Okay, so here we go. Are you ready? HCG comes in a powder and a fluid. So what you're going to do, the powder has 10,000 units. So assuming we're all talking about the same HCG, it has 10,000 units. So in order to get 500 units in 0.1 mils, you need 5,000 units per mil. So that 1/10 of that is 500 units. So you take 2 mils of the fluid and you inject it into the 10,000 units, which gives you 5,000 units per milliliter, because now you've got 10,002. So that's 5,000 per 1. From that, you need to know the volume of air in your catheter first. So you got to measure that. So they need to know how much air is in their catheter. So first you pull up the air, then you pull up the 0.1 of the HCG into the needle. Then you connect, not the needle, the syringe, sorry. Then you connect your IUI catheter, and you've got to depress down to the almost the 0 mark, not quite. And that will allow you to have your 500 units in the catheter with a minimum amount of air, and the air that's in there will push the fluid out. If you don't put the air in there, half of your 500 units will stay in the catheter. The catheter is an IUI catheter. You could do it with an IVF catheter, but IVF catheters are super expensive, and they're not designed to hold 0.5 mil. They're designed to hold microliters. So you really want to do it with just an IUI catheter. You pop that in, you pull it out 15 minutes ahead of time, and then you wait until the 15 minutes has passed, and then you do your embryo transfer with a IVF catheter, which is different from the IUI catheter. That's at least what we do. You could use an IVF catheter, but I would definitely not use the same one. Once that IVF catheter is out, you don't want to be sticking it back into an embryo culture dish, because it's potentially contaminated with anything it touched on the way in and out of the vagina, not to mention the air. So if they're doing that, that's super cheap, and I would never advise that.
Are turmeric supplements and pomegranate juice helpful for reducing inflammation or thickening lining before embryo transfers?
Turmeric, probably, but there's no studies on it. Pomegranate juice, I've never looked up before. I'm sure I can find something. Let me try this. Pomegranate, what am I going to look up? Pomegranate and fertility. Pomegranate and infertility. Yeah, I don't need meta-analysis. Just give me anything. Therapeutic applications of pomegranate. Potential applications, male infertility. Astragalus membranaceous and punica grana. I don't even know what the hell those things are. Small RNA. Oh no, that's got to be something. Effect of pomegranate peel extract on histopathology, testosterone levels, and sperm of testicular torsion detorsion induced in adult Wistar rats. They've got a randomized controlled trial of using it in PCOS women. Let's check that one out. That actually is good. Of course, Persians, because we all love pomegranate.
Pomegranate.
Have you seen my fancy pomegranate? You got to grab my fancy pomegranate. The green one up there. It's green. I don't know why it's green. Okay, so
For all intents and purposes.
yeah, PCOS is associated. Yeah. What did they do? This study aimed to examine the effects of concentrated pomegranate juice consumption on risk factors of cardiovascular disease in women with PCOS. In this randomized clinical trial, 44 PCOS women with some extra weight were put in. What did they end up finding? They reduced blood pressure by almost 10 points. Wow, that's significant. Diastolic blood pressure by 4 points. Your triglyceride levels dropped a lot. LDL dropped a lot. So it looked like things were better. There you go. So pomegranate
I'm a
juice.
big believer in pomegranate juice.
I don't love pomegranate juice.
You
I love
gotta sip it.
I can eat pomegranate all day long. My mom peels them
it
for us.
Yeah.
Yeah,
Very
right.
hard to open.
The classic Middle Eastern mom.
I don't know how to open it.
But-
I use my teeth.
but I cannot drink the juice.
Well, it doesn't taste the same.
It's too tart.
It's done.
But pomegranate's awesome.
Yeah.
I think we're done. Anything else?
Yeah. You've done is quite a question mark.
Okay, so you know what? You want to photo pick your questions and I'll try and pile them in somewhere?
Yeah, sure.
Okay, we're going to screenshot your questions. I'll answer them personally over the next few days and on the weekend. However, one thing we would like to ask you guys is one thing that we thought of, which might be of interest to you guys, is maybe we would move the show to being every other week, but in the interval weeks, we would do a custom video on a topic without answering questions, but kind of like the unexplained infertility, which would give us time to make the video. Let us know your thoughts, comment on our YouTube channel or on Instagram. Tell us what you think about that. We would be happy to hear your thoughts and see if you want us to continue every week like we always have for the last, is it coming up to 4 years now?
I feel it's coming up to something.
I think it's coming up to 4 years now. For the last 4 years, or we can switch it up a little and we will do it 1 week with a video, 1 week with the live show. Let us know your thoughts. And as always, be safe. And we do have some exciting news coming up. So we will share that with you guys hopefully next week sometime. So we'll let you know and we'll go from there. Stay tuned for lots of amazing stuff coming out of VRC. Take care, guys. Have a good night.
I just want to share with you, they said you rocked answering that one question.
Oh, cool. There you go.